Erev Tov, everyone. We are going to get started. I know people are still coming in, and this will be recorded for those who may have missed. So you can also share it with others. We are incredibly blessed and grateful, and there just aren't enough words that are synonyms of gratitude to our doctors and our community who have been supports and guides in times that are incredibly turbulent and uncertain, and especially to the doctors that are going to be connecting with us tonight, guiding and speaking to us, to Gil, to Sharon, to Julie, to Zach. We're so lucky that they have been with us throughout this time that none of us would ever want to go through, but they have been at the head of it, supporting us. So we're going to hear their wisdom and check in on some things that, maybe we've been hearing in the news, but they're going to give us some of the facts on the ground about how to approach the vaccine, the COVID-19 vaccine, as well as how spiritually we can treat this moment in time. So we're going to start. I'm going to share some halachic reflections. Rav Yosef's going to speak after me. Then we're going to hear from the doctors. And after that, we'll have an open Q&A. And one of our biggest priorities tonight is to make sure that everyone gets a chance to ask the questions that are burning on their hearts about this, because this is a unique opportunity to be with people with such wisdom. So within the halachic context, because we're certainly speaking about the medical issues tonight, there is a chiyuv. There's a very real obligation for us to get the vaccine in alignment with our doctor's guidance. And the question of what that chiyuv is what I'm just going to spend a few minutes exploring. The chiyuv, just to bring it down to a couple of words, is about protecting ourselves and protecting others. And I want to thank Dr. Sharon Stein-Merkin for sharing this beautiful article with me that anyone who's interested is welcome to, I'm happy to share with them too, on the Jewish ethics regarding vaccination by Suriel Rashi, that really details in a thorough way the history of vaccinations in relation to halachic practice. But within that article and far beyond it, there's really like 2 points of chiyuv that we're speaking about. And that's the first connected to Pasuk in Devarim, V'nishmartem be'od lenafshetechem, that you shall watch yourselves very well. And then in Vayikra lo tamod al dam re'acha, that we're not supposed to stand idly by on our fellow's blood. The latter is, of course, explored in the Gemara as a reminder that if we see someone who is in a life-threatening situation, that we have an obligation to step in. So there's an additional halachic principle called chamira sakanta meisura, that danger is more serious than sin, meaning that we need to prevent any danger to life that we may come across. And from this notion, there's many tshuvot that have been written and were particularly detailed in the article that I mentioned, that since the time of the smallpox vaccine, 1796, created by Edward Jenner, that the rabbis have been in complete agreement. There's halachic unity approaching the fact that there's a religious and ethical obligation for us to protect ourselves, each other, our children. So even from the beginning of vaccines, kids in the Jewish community were receiving vaccines because it's such an incredibly important thing to do. Who would disagree with this? Because of course there are those who do. There's many reasons that someone might approach it, but the primary one I think we often hear is that those who disagree say that it might be showing a lack of faith, that we should trust that Hashem will heal us, or that it's rejecting Hashem's punishment because there's some ideas that perhaps sickness comes from Hashem as a way for us to atone for sins in this world. But it's really quite the opposite. God created us with the ability to heal. And for this reason, to refuse vaccines or medical support in general is rejecting the divine gift that God gave us, which is God gave us the ability to use our minds to heal, to provide fantastic science and technology that can bring about protecting and preserving life. So it's rather the epitome of faith to embrace modern medicine in this way. And we can think of Verapo Yerapeh, the chiyuv in the Torah of what becomes the doctor's responsibility to care and provide healing whenever possible. So sort of a background framework framework for us to think about what chiyuv, what obligation we have in protecting ourselves and others. There's two images of what we'll call protection that I think are powerful to hold in our mind as images of what it is that we are doing. And I'm going to share both of them, one regarding the self and one regarding others. The first is that in being told Hishamer lecha u'shmor nafshecha, that we are supposed to be very careful and watch ourselves closely in Devarim. Rambam explains that there's a halacha that we are supposed to put a fence or a railing or a parapet on a roof, on something that might be dangerous on our home and in spaces in our territory, in our reshut, that we are responsible for. So if there's a hole in the ground, we're supposed to cover it. We have to do everything we can to make sure that no one in our space is going to be in danger. So this Rambam tells us, Maimonides says that this is a mitzvah aseh, a positive commandment to remove any sense of danger. And anything that we can do to prevent illness is something that is required of us. So that's the first image, is of the self, that in our homes, we are supposed to create, put up railings when possible, put up the parapet on our roof. The second image is that of a walled city. The Shulchan Aruch paskins that all residents in a town have to share the costs of guarding that city and making sure that the wall is taken care of around that city so they're all protected. So even if avoiding doing so isn't going to have any sort of personal consequences for one individual, nevertheless, there's a responsibility to the collective and to the community, and all are still obligated. So what we have there is an emphasis on our obligation to care for the societal benefits of others, to care for the greater public, in addition to just our own home. So we can think about this in the context of vaccination, that when most people vaccinate, then we're all likely to be safe or safer. But if most people refuse vaccination, then hundreds of thousands of people are impacted, God forbid, die from severe illness. The last thing I'm going to highlight is Rav Asher Weiss paskins. He rules that the minority can't refrain from vaccinating our own at the expense of the majority vaccinating, meaning that I can't say that I'm going to wait for everyone else to do it, because if everyone said that, then no one would ever end up vaccinating. And that's sort of like a much wider responsibility when we think about the public and the collective and how we make sure to protect each other. So again, we're thinking about the chiyuv we have d'oraita from the Torah, and certainly supported throughout rabbinic literature, that we have an obligation to protect ourselves, to take care of our own bodies, and also to protect others, meaning our immediate family, our community, B'nai David family, the wider community, strangers. We have an obligation, whether it is to put the parapet on our own personal home, or if it's to be invested in building the wall around the city. So I offer those two images when you get asked, or when we think to ourselves, where do I place or situate this moment in time in halacha? Thinking of the parapet on the roof and thinking of the wall around the city are two, I think, very constructive and powerful ways to visualize the protection that we are reflecting on this evening. So that's the intro on the halacha and the chiyuv. Rav Yosef is going to now address the spiritual experience behind this.
Thank you, Rabbanit Alyssa. Friends, ours is a spiritual system in which we seek the face of God, not only at the times and on the occasions when the system directs us to seek the face of God. We also seek the face of God on occasions and at times when our hearts direct us to do so. And the time, sometime in the coming weeks or months, when we will be rolling up our own sleeves, will certainly be a time at which our heart directs us to seek the face of God, which leads directly to the question, what is the bracha upon receiving the COVID vaccination? And I'll begin my response to that question with an admission. There was at least one moment, and likely more than one moment over the course of 2020, when I turned to God and told him that I was unimpressed with the job that he is doing, which was a very presumptuous, even arrogant thing to do, but it was spoken with sincerity. It was directed by the heart. And now, these months later, as I and you contemplate the prospect of vaccination and the promise that it holds, our hearts again direct us, this time, to turn to God with gratitude. And even more so at the moment when we are ourselves becoming immunized from this disease. We are directed by our hearts to turn to God not only with gratitude, but also with joy. Joy over the knowledge that the nightmare will ultimately lift. Joy over the knowledge that the loneliness and the isolation and the distance from loved ones and community will end. And our tradition has not one, but actually two brachot that are intended to express this kind of joy. The first bracha will, I'm sure, come as no surprise to anyone. It's the bracha that, in the words of the medieval sage Rabbeinu Asher, was composed precisely to express the joy of the heart. Blessed are you, God, who has kept us alive and sustained us and brought us to this day. The bracha of Shehecheyanu is unquestionably a halachically fitting bracha for the moment at which we become personally vaccinated. At the same time, there is a bracha that is likely better than Shehecheyanu in this particular context. Baruch atah Hashem Elokeinu melech haolam hatov v'hametiv is the bracha that is reserved for moments when the joy in our hearts is not only for ourselves and for our good fortune, but extends beyond ourselves, in this case to the people in our community, in our society, the people in our species, who just like us are seeing the light of a new day beginning to dawn. The bracha of Hatov v'Hametiv is an even better bracha to recite upon being vaccinated. And this is especially so because one of the things that we will have to make a reckoning about in the near future is the spotty and uneven record we have cumulatively compiled in terms of empathizing with and caring about others during these past months. This is expressed through our society's inconsistent willingness to take the necessary measures to slow the spread of the virus, an inconsistency which is with us literally right up to this moment. A reckoning is in the offing, and a symbolic but very positive place with which to begin that reckoning, with which to begin the tikkun that is going to need to happen, would be to dafka think not only about ourselves and our own joy, but to think about others and their joy at the moment that we are ourselves being vaccinated. To recite Hatov v'Hametiv, turning to God as directed by our hearts and expressing joy not only for the fact that our lives are about to get better, but for the fact that the lives of everyone around us, those lives will also be getting better. Hatov v'Hametiv is an even more appropriate bracha. Hatov v'Hametiv is a more healing bracha. Hatov v'Hametiv may help us begin to fix and repair that which so tragically came apart and to an extent even right now is still coming apart within our community and within our society. Friends, after a year in which we have been disappointed with God's performance, we have the opportunity soon to direct our hearts toward God with gratitude and with joy. And while we do so, let us direct our hearts as well to all the human beings who surround us. Looking forward to saying that bracha together with you.
Thank you so much, Rav Yosef. We're now going to turn it to Gil.
Myself. Okay, well, thank you, Rav Yosef and Rabbanit Alyssa, for hosting this program and for your very inspiring stewardship of our community during this entire pandemic. Rav Yosef, you spoke about the past year, and you've really helped to navigate our community through these trying times, and our great appreciation to you both for your leadership during this time. Also want to thank you for hosting this program tonight, and I'm joined by esteemed colleagues Sharon Stein-Merkin, who's an epidemiologist at UCLA, very much having had the pulse of what's been going on with this COVID-19 infection over the past year in our community and in our state, and by Zach Rubin and Julie Higashi, really stewards of LA County, who are infectious disease specialists that have been right in the forefront of navigating for our entire Los Angeles community and being involved in many levels high up about how our community at large should be engaging over the course of this pandemic. So very much a privilege to be speaking to you all tonight. What we'll be doing over the next half hour or so are a discussion with some prepared remarks about what the COVID-19 vaccines are all about. We'll follow that with common vaccine questions and misperceptions that Sharon will cover. And then Julie will lead us through an understanding of prioritization, at least on our local level, and what we're hearing from the government with respect to vaccine administration. And we'll use the remainder of the time for question and answers. So what I'd like to do over the next 10 minutes or so is go through what is this vaccine about, is it effective, and is it safe? And I predicate these remarks really on hearing questions from my own patients and hearing questions that are being directed at me by people who really want an understanding of what the vaccine is so that they have confidence in its safety and effectiveness. There's a lot of news about the fact that these vaccines are new. There's technology that's new, that the vaccines have been produced in a very short period of time. So can we trust their effectiveness? Can we trust their safety? And I think by providing some of this context, I hope to give you some of that reassurance. So just a basic framework for what are vaccines in general. Really, vaccines are intended to inject into your body a weakened or killed form of a virus or bacteria, and that your body then takes its own immune system and reacts to whatever is injected in there and creates what are called antibodies. Antibodies are these green Y-shaped proteins that are on the middle of your left side of your screen. And then those antibodies are very, very specific to only recognize that particular virus or bacteria. And then when it's reintroduced at some point later, because you're actually exposed to an infection, you have those antibodies that remember how to react against it, and your body's able to fight off that particular infection. That's sort of the traditional vaccines through how most of our vaccines historically have been developed. With respect to newer vaccines don't actually involve injecting the virus or the bacteria itself, but just a part of it. And you can see here on the right side of the screen that an antigen, which is a protein, which is just a little piece of the virus, may be sufficient to prime our body's immune system to recognize it when the actual virus comes into play. So this is the SARS-CoV-2 virus. This is the virus that causes COVID-19. You can see in the upper right a schematic of the virus. I'm sure many of you have seen these on the news of what it actually looks like. But here's a cartoon on the left side of the screen, and you can see that the virus has inside of it its genetic material, but on the outside of it are what we call the spike protein. And I want you to remember that, because the spike protein is really the part of the virus that our vaccines are directed against. The spike protein is on the surface of the virus, and part of how the virus actually gets, the way that the virus actually gets into our own cells when someone gets infected, is that the spike protein attaches onto cells in your own body. And that's what's shown on the right. Without that spike protein, the virus is essentially not able to enter cells. And the spike protein surrounds the virus, so that if we can figure out a way to attack that spike protein, we can essentially inactivate and render the virus harmless. One question that, as I mentioned, has come up a lot, as I'm sure has been on the news and others, is the rapid pace with which this vaccine has been developed. On the left side of the screen is a schematic showing traditional vaccine development, which can take 10 to 15 years from the very beginning of designing and exploring the proteins that should be inside the vaccine, through various phases of clinical trials that can take several years, and then ultimately a year or two for actual approval. But these vaccines that we're seeing now were developed in the last 10 or 11 months. How is it possible that what we're able to achieve today in 10 or 11 months is just as safe as something that was produced over 10 to 15 years? And the answer is that corners were not cut, steps were not skipped through a series of either serendipitous and fortunate coincidences. Like, for example, for 10 to 15 years, we've actually had coronavirus vaccine sitting in a freezer from prior SARS infections that companies had started development of vaccines for using new mRNA technology that we just didn't need, but they were able to take them out and quickly tweak them to sequences that quickly emerged when COVID-19 emerged. In addition to that, there was rapid development through the clinical trial phases, because authorities allowed for various phases of vaccine development to occur in parallel rather than to occur in sequence. And so by doing that, they were able to accelerate the clinical trial phases of many of the vaccines that are currently in development and that have already been authorized. Furthermore, unlike in traditional vaccine development and traditional drug trials where the FDA waits until everything is finished and only then do they review all the data, the FDA and other health authority regulatory bodies have been reviewing the data on an ongoing real-time basis, so that they didn't have to wait until everything was finished before reviewing everything. And so these are just some of the reasons how the pace of the vaccine development has been so robust and so accelerated, but yet still following every single step that is required for ultimate FDA authorization and approval. I also want to make a point about the fact that there will be many different COVID-19 vaccines. We often talk about the vaccine, but there are many vaccines. There are over 100 vaccines, some of which work very differently from one another, that are currently in development. The two that are currently authorized by the FDA happen to work the same way. They are what we call mRNA or messenger RNA vaccines, and I'm going to talk a little bit about how those work. But there are others that involve injection of a protein, Novavax, which is actually in the news today, that they're starting phase 3 clinical trials. AstraZeneca, I'm sure many of you have heard of, they use a different mechanism of introducing that protein into the body cells. So there are different mechanisms of how some of these vaccines work, but what we have today are the 2 mRNA vaccines that are authorized, and I'm going to walk through exactly what that looks like. So the mRNA vaccines, if you look on the left side on the diagram, mRNA is genetic material that codes for a protein, which means that your body inside every single cell of your body has the ability to take that genetic material and create protein out of it. So with the injection of the vaccine into your arm, that mRNA gets injected into your arm, and the mRNA is taken up by various kinds of cells, various kinds of immune cells in your body, and then they start producing the protein, that spike protein that we mentioned earlier, which is on the outer portion of the virus. So we're not actually injecting the virus. You cannot get the virus from the vaccine. We're actually injecting a coding material for that spike protein only. And then our body produces antibodies against that spike protein. So if in the future we encounter the actual infection of COVID-19, our body will be primed and ready to attack it with those antibodies that develop from the vaccine. So as I mentioned, this technology actually has been in development for many years, although there has not been a prior mRNA vaccine that has been licensed and authorized for use. mRNA itself, this genetic material, is temporary. Some people want to understand, is this mRNA going to get encoded into my own DNA, into my own body's genes? And the answer is no. mRNA will get rapidly destroyed within probably a few minutes after it's administered, once your body is able to start processing it and creating antibodies. It's packaged in what we call lipid bubbles, little fat, little tiny bubbles that actually carry this mRNA material. And that's a new technology as well. You've all heard, I'm sure, that the fact that these vaccines need to be kept in very, very cold temperatures. And the reason is because these lipid bubbles, once at room temperature, will dissolve. And so the packaging of this genetic material requires these very, very cold storage temperatures, which is one of the limitations of the currently available vaccines. So I want to talk briefly about the vaccines that we have currently available and authorized, the Pfizer vaccine and the Moderna vaccine, and some of the data from the clinical trials. Just to give you the context, Pfizer is almost every vaccine, by the way, is 2 doses. There's only one in phase 3 trials that's a single dose vaccine. So we can probably anticipate that by the time the general public is offered vaccinations, most vaccines still will be requiring 2 doses. Pfizer are 2 doses 3 weeks apart. Moderna's vaccine is 2 doses 4 weeks apart. I listed some highlights from the clinical trials. Pfizer had 37,000 study participants. They were randomized to receive either the vaccine or placebo. And at the end of the study period, there were 170 cases of COVID-19 after the second dose. 162 of those were in those that received placebo, and only 8 were in those that received the vaccine, reflecting a 95% efficacy. There were 10 severe cases of COVID-19, 9 of which occurred in those that received placebo. With Moderna, it was almost identical results, which is remarkable. 30,000 study participants, again, randomized 1-to-1 to vaccine or placebo, and they had 196 cases of COVID-19, of which 185 were in the placebo group and only 11 in the vaccinated group, also over 90% efficacy. There were 30 severe cases in this trial, and every single one of those 30 cases were in patients who had received placebo. This is a visual schematic from the Pfizer trial. And what you can see here is a diagram over time of what happened to the study participants. And in the blue are those that received the placebo shots, and in the red are those that received real vaccine. And you can see that over time, beginning from about 12 days after the first shot, you need 2 shots, but after the first shot, those 2 curves start to separate from one another. And that red line are the number of cases of COVID-19 in patients who got the real vaccine, and again, compared to the placebo. This is a remarkable, remarkable difference. I just want to point this out for those that are seeing this for the first time. If you think about or understand what our prior vaccine response rates have been, for example, the flu shot is about, different years are different, but about 50% effective compared to maybe 20% in placebo recipients. So 50 versus 20%, that's good enough. Our public health guidelines generally recommend a flu shot for everybody every single year. Here we have 95% compared to 5%. Which is it's almost an unheard of distinction in terms of vaccine clinical trials from what we're seeing. And what's also very remarkable is that both the Pfizer-BioNTech vaccine and then shown here is the Moderna vaccine had very similar curves, very similar rates of vaccine efficacy. Side effects, certainly everybody wants to understand what are the side effects. These, I want to point out, in a clinical trial are what we call solicited side effects, which means that after you got your shot, somebody called you and specifically asked you, did you have an injection site reaction? Did you have fatigue? Did you have a headache? Did you have muscle pain? And so you're more likely to see higher rates of people reporting things than if you ask them, did you have a side effect? But this is what's reported. So we see here pretty high rates of injection site reactions, which are typically a sore arm, redness, or redness at the site of the injection, fatigue, headache, muscle pain, chills, joint pains, and fevers, and the percentages that are shown there. These were all transient and short-lived. There were some serious or severe adverse reactions. Fatigue, muscle aches, joint aches, headache, pain, or redness at the injection site. Approximately in both vaccines, approximately about 15%, 15%, and most of the severe reactions occurred after the second dose. Interestingly, the more severe adverse reactions were more likely to occur in people younger than the age of 55 compared to people over the age of 55. And it's thought that probably some of these reactions are due to your immune system just being revved up by the vaccine. Your body's rapidly generating all these antibodies against COVID-19. And so that's part of these reactions that we're seeing are actually normal immune responses to antigens. There have been some, after the vaccines have been authorized, there have been some allergic reactions that have been very severe that have been reported. Just want to put it in context. The last I checked, there were 6 reported cases. There may be more by now, but over 2 million doses of these vaccines have been administered. So just want to put that in context of numerator and denominator, 6 cases out of 2 million. And these 6 were in individuals who previously did have histories of severe allergic reactions. So just to quickly summarize our CDC recommendations, the vaccines are licensed for people over the age of 16, regardless of prior COVID-19. Julie will be talking to us about prioritization, so I'm not going to get into that in terms of the priorities of who gets what when. Specifically to address the reactions, for almost everybody, unless you've had a reaction to a specific ingredient in the vaccine, these vaccines are going to be recommended. It's just a question of how long somebody might be monitored if they do have a history of allergic reactions. There are special considerations around pregnancy, and we'll also be talking about continued precautions after vaccination. Even though you might be protected, we don't actually know whether or not somebody who's received vaccination is still able to transmit the virus, even though they're not themselves are not sick. And so for now, public health recommendations are to continue all forms of social distancing, masking, hand washing, et cetera, after vaccination. And then just to end off, there's a lot of things we still don't know. This is still early on. We don't know how long immunity will last. We don't know if people are going to need a second booster dose or doses. We don't know, again, about asymptomatic spread. And we don't know when things will be back to normal. If we have time in the panel discussion, I'd love to hear my colleagues' predictions on that. But at this point right now, I think it's really too early to say. So with that, please, if you have any questions, put them in the chat box. We'll have a chance to get to them during the Q&A, and I will turn this over now to Sharon Steinmarket.
Thank you, Gil. Hi, everybody. First of all, as I'm sharing my screen, I just really want to thank Gil for putting this together and organizing this really important discussion. So let me just, okay. Okay, you all see this okay? No?
No, we're seeing just a piece of your screen.
Oh, interesting. Hold on, let me try again. 1 second. That's strange. Okay, how about now?
Yes.
Yes, okay. Okay, so as Gil mentioned, I am going to be talking about some common questions and concerns that people have, that may arise about this vaccine or the vaccines. Gil talked about the vaccine safety and can I trust the vaccine developed so quickly? So I'm not going to spend a lot of time on that. I want to jump into the third question listed here. Why, if I am not particularly high risk and I, have I'm lucky enough to work at home, why can't I simply wait and just, see how everyone else does and take the vaccine when I'm certain about it and when I feel like doing it? And I want to give an answer to that based on an epidemiologic answer. So Rabbanit Alyssa talked about perhaps a religious answer, a halachic answer, that we have a responsibility to the collective. But I want to explain from an epidemiology perspective why it's actually important from a scientific scientific perspective as well. So I'm sure a lot of you have heard the term herd immunity. It's kind of funny because normally epidemiology is a pretty esoteric scientific field, and a lot of the phrases are just becoming very commonplace. But I want to clarify something. Herd immunity is not some kind of nefarious political program or public policy. It is actually an actual epidemiologic term. It is a concept that describes the balance of immune, so people who cannot get infected, versus susceptible people in a population. And this balance basically prevents an outbreak or an epidemic. So we are trying to achieve a situation where we have resistance to an outbreak or an epidemic for a particular pathogen, in this case, COVID-19. And in order to get to that herd immunity, the way we get to herd immunity is through vaccinations. Vaccination programs have been remarkably successful. In fact, probably the most successful public health efforts ever have been vaccination programs. Through these programs, we have made commonplace, diseases rare. And in one case, smallpox have eradicated the disease entirely. So herd immunity is very important for that effort. Let's look at an illustration of how herd immunity might work. So if you look at this top rectangle, right? So you have a situation where these blue individuals are, not sick, but they're susceptible to infection. These two red individuals are sick and contagious and spread this infection has widespread contagion, resulting in our situation in a pandemic. In the second rectangle, we have a situation where only some individuals in the population are vaccinated, those that are yellow here, okay? These few individuals will in fact be protected. They will not become sick. These are the yellow individuals here. However, most of the rest of the population still has been infected. In this last situation, obviously simplified, but a situation where we have theoretically achieved herd immunity, we have most of the population vaccinated, which results in not only those people who have been vaccinated being protected, but also protecting individuals, the few individuals who have not been vaccinated, kind of protecting them in a bubble, okay? Now, the premise here is that not everyone can be vaccinated. So those who are severely immunocompromised, in our case, those who the approval for the vaccine is not extend to, so in our case, children, for example, they cannot be vaccinated at this time. This kind of herd immunity approach allows for protection of everyone through the majority being vaccinated. Now, what is this threshold? So I know you've probably been hearing in the news about our herd immunity threshold that we have to achieve. This is difficult to pinpoint. This is something experts are not being cagey about. It's really something we don't necessarily know. So herd immunity thresholds really are factors of three important things. The effectiveness of the vaccine. So how effective is the vaccine? In this case, we estimate that to be 95%. Around 95%. The second thing is the transmissibility of the pathogen in question. And the third thing is movement, right? Interactions between people that is obviously very variable. So there are times when herd immunity thresholds differ place to place, which will probably be the case here. The average or the estimated range that's being suggested right now is between 70 and 85%, which means probably closer to 85% because we're in the middle of an active epidemic. Closer to 85% of the population will have to attain immunity for all the transmission to stop. Okay, so for the transmission will slow down as more people, this isn't a binary yes or no, this transmission will slow as more and more people get vaccinated, hopefully. But we won't really see the pandemic stop or dissipate significantly until a really big majority of the population is vaccinated. So how do we get to this estimate that is being questioned a lot in the news? This estimate really is taken from other diseases that we know more about. So for example, measles is a highly transmissible disease, is extremely contagious, more so than COVID. The vaccine is 98% effective actually for measles, and more than 90%, or at least 90% of the population has to attain immunity for there to be no measles outbreaks. When we see measles outbreaks, as we have in the past several years, herd immunity has been breached because there are groups of people who just decided not to take it for a variety of reasons. So when our herd immunity is breached, we expect to see outbreaks. Going back to the question, why should you wait, right? So herd immunity is the reason that you should not wait, because aside from your own personal protection, when you get this vaccination, you are not only protecting yourself, you are very directly contributing to the protection of your community, your society, even the world's ability to end this pandemic. Okay, so when you get that shot, keep that in mind. This isn't only a chesed. This is actually, it is a chesed, but it is also a scientific, contribution to actually ending the pandemic. If we're in this middle situation where some of us are protected, we will not see an end to the shutdown and the lockdown and all the societal restrictions. And if this pandemic has taught us anything, it's that we really rely on each other, especially with a communicable disease, to end this transmission. I just want to let me bring up the last question. So the last question I also posed is, once I'm vaccinated, can I take off my mask and go back to normal? There are a number of reasons that we are saying no, that you can't, not yet. One of them is, of course, the herd immunity reason, right? So until everybody is vaccinated, we need to maintain the societal precautions because we're going to still have circulation and transmission of the virus. The other reason is that while the vaccine is very effective, as Gil was saying, really beyond some of the more recent vaccines, like for flu, it is not 100% effective, right? So that 5% is low, but when there is a lot of circulating virus, 5% is still a lot of people. So we have to still be careful once we're vaccinated until we reach this herd immunity. And the last reason is, as Gil mentioned, in those clinical trials, our endpoint there, the outcome there was symptomatic COVID. So we know that the vaccine is effective in preventing symptomatic COVID, disease. However, we are not totally sure about those vaccinated still being carriers and possibly transmitting disease. So it is important to keep those precautions in place. And I just want to end with, of course, there are other questions, and I welcome, I want to give Julie a chance to speak, and I welcome additional questions at the end. But I want to end with this graphic that some of you may have seen that a virologist created some months ago that I think is very relevant and to how we think about this. So we have a lot of things in our toolbox to help prevent transmission and COVID disease and death. And one of the most powerful tools in our toolbox right now is going to be the vaccine. But there are other tools that we have to keep using because, as in this graphic, right, we don't want the holes. We want to stop all the holes of the Swiss cheese. And the vaccine is going to be a very good slice of cheese, but we can't forget the others because, again, we're in the middle of a pandemic. It is not often that we have to try and attain this herd immunity while we have very high levels of circulating virus. So let's keep that in mind. Eventually we'll get there, but it's something that we have to consider as we have our turn to take this vaccine. So thank you, and I will give it over to Julie.
Okay. All right. Hopefully this is what. Okay. There we go. Okay. Well, thanks. You all are a really tough act to follow. I'm really honored to be part of the panel. I'm going to be talking about the COVID-19 vaccine prioritization and distribution. Oh, this doesn't really project that well, but to date, we have started in the United States the distribution of vaccine. And I think the overall kind of understanding of where we are is that we're not quite where we would like to be. So it was projected that we would have distributed 20 million doses. I think we're about halfway there. This is as of a day ago. As far as distribution, we've got 2 million people having received the vaccine in the US. There's a definite lag to this, but this is on the CDC website. Here's the link. And so you can track this, what our progress is. And, you know, I think this represents the initial foray into getting vaccine to people. There have been some hiccups. I think they're being worked out. And what we hope to see is a rapid escalation. So I think everybody is sort of thinking, will there be enough vaccine for everyone? And so the answer is right now, we don't have enough vaccine for everybody right away. We all know that kids under 16 are not, the vaccine's not authorized for use yet, but you know what? Trials are ongoing. And as we've seen, they are being completed rather quickly. And so I believe that we're hoping that, you know, come spring, we're going to be able to start seeing even the kids be vaccinated. So in determining who is going to be vaccinated, there are advisory groups that have assembled at the federal, state, and local level, and there are balancing safety and equity and recommendations. So the federal group is really the group that I'll talk a little bit about that set the policy. And then at each level, there's more that is being debated based upon that state's local epidemiology and the ongoing, just sort of all the factors in the state. And then that gets passed on to the local level, like Los Angeles County, we're the local health jurisdiction, where again, there's another layer of decision-making. And so really the considerations of these groups are really looking to decrease death and serious disease as much as possible. We want to preserve functioning of society because we do want to, you know, preserve our economy, and also reduce the extra burden that COVID-19 is having on people already facing disparities. And I think that speaks to a little bit of what Rav Yosef was talking about when he was saying, let's be joyful about receiving the vaccine for ourselves, and then what that impact is going to have on the broader community. So who's making the decisions regarding prioritization? And at the federal level, it is this group called the Advisory Committee for Immunization Practices. And those of us in public health all know this entity as ACIP. And they make decisions, not just COVID vaccine, but all vaccines for Americans. There are a bunch of these advisory committees, and they all advise the Health and Human Services Agency. So this is Alex Azar right now is our HHS lead. And these advisory committees, I've served on one for tuberculosis, assemble all the sort of subject matter experts from all different parts of the government and all the states. And so it's going to be several dozen individuals. And this group has been meeting regularly, multiple meetings, dozens of meetings, in order to debate how the vaccine should be distributed. They're considering, they have ethicists on these committees. There's definitely health people, there's policy people, FDA is on this committee. And so they're looking at all the angles. And so what they've done is they have, CDC participates in this panel, and ACIP hands down the recommendations, and CDC published the recommendations in what is the CDC's journal, which is the Morbidity and Mortality Weekly Report. We all in health, all our healthcare folks know this as the MMWR. And we've had 2 publications released recently, December 3rd, and these are the citations. And so for phase 1A, the first people that were decided to receive the vaccine were healthcare personnel. And in our country, there's 41 million of those folks. And then long-term care residents, of which there are 3 million. And then a few weeks later, the next group of determination, and again, this is being called phase 1B and 1C, are, whoops, sorry. I'm just having to move my own, sorry, I've got to move my windows here because I can't see. Phase 1B, 1C, and phase 2 are the next people in line. So frontline essential workers, of which there are 30 million, and people over 75 years old, 21 million. Thereafter, there'll be persons aged 65 to 74 years, and then persons with medical conditions aged 16 to 64 years, as well as other essential workers not included in phase 1B. And then phase 2 is really everybody else. Let's see here, I'm still having problems with this, okay. And so really the vaccine is released to state and local governments for distribution. And it is at the state and local level where most decisions are being made. LA County, being the largest local health jurisdiction in California, is always included in any decision making across the state, and our very own sort of head of, there's definitely the sort of the person in charge of our vaccine program here in LA County is sitting on the state committee. So this is our LA County in this plan for distributing vaccine. You can get this, you can look at this on the LA County coronavirus website. If you just Google LA County DPH coronavirus, you'll come to the public page and there's a vaccine button that is very easy to see. You click on that button and there's a lot of good information on the vaccine here and the plans for LA County. And so here we see that this is the kind of decision-making that's happening at the local level for phase 1A. All of these are being broken up. Phase 1A, which is healthcare personnel, are being broken up into subcategories. So tier 1 are people that have already received vaccines. So I would say that very many people have at the acute care hospitals have already received vaccine. I think I got some information that by the end of this week, both at private and public hospitals, the county hospitals will be, by and large, many of them completing their vaccination as far as the first dose for their healthcare personnel. And I think that what is being launched now is the skilled nursing facility, health workers and residents. And so we're deep into tier 1 already at this point. I think in the coming weeks, we'll be launching into tier 2. This is the tier where I'm falling. So I have not yet received a vaccine. And so there's public health field staff, and these are the ambulatory clinics. So the ambulatory care is concentrated in this tier. And then tier 3 is another group of healthcare personnel. So you can see that this is what is being broken down. And then phase 1B, here we have the people 75 years and older. We'll talk a little bit about the way that we think the timing might happen. It's very unclear. It's a real dynamic situation. But I believe that, we're looking probably at February, March for phase 1B. That's our hope. And the timing again is really going to be dependent on how quickly we're able to ramp up. So these are the initial frontline essential workers, our first responders, our educators, folks in food and agriculture, manufacturing, corrections workers, U.S. Postal Service workers, grocery store workers. These are the essential job categories that are being prioritized to receive the vaccine in phase 1B. And then here we have the phase 1C and phase 2. Where are the kids going to fall into this? We really don't know. It's all going to be dependent upon how long it takes to do the testing and the trials. And hopefully we'll get authorization to immunize kids under 16. So I just wanted to mention some of the medical conditions so people could be aware about who is known to have increased risk. So if you have one of these conditions, you should be working with your doctor to make sure that they know that you're interested in receiving vaccine. And so people with cancer, chronic kidney disease, chronic obstructive pulmonary disease, heart conditions, weakened immune systems, obesity, pregnancy, sickle cell disease, people who are smokers, and type 2 diabetes. So these are known categories of people who should be prioritized to be in that 16 to 64 group. These are medical conditions where there's possible risk for severe disease. I think there's a lot of movement. They may or may not be considered as a medical condition, but I think that there's more information that we're learning about all these diseases as time goes on. And so I would say if you have one of these conditions, this is something you're quite likely to be prioritized as well, but it is an evolving situation. This is what the timeline that the county has on its website for really this initial few weeks. And you can see 12/15, 12/20, this is right now, this is what is happening. And again, I believe that the timeline we're keeping to the timeline pretty well from the standpoint of a lot of the acute care hospitals receiving vaccine and actually going through quite a bit of vaccination of their healthcare workers. It is this long-term care facility phase is being launched as we speak. And in fact, I was hearing today that DPH is actually mobilizing strike teams to accelerate the vaccination in this category. So where will I get vaccine? Because that's a natural question. I think if you work in healthcare, you can look to your employee health. If you're in a large institution, and then as I understand, many of the hospitals that have vaccine are reaching out to the providers who are associated or have privileges. And so that is one way for you to get vaccine. And again, those people are going to be looking and getting the vaccine right now through January for long-term care facility residents and staff. It's commercial pharmacies have a plan for distribution. This is a really interesting time for us. I don't think we've ever had such a public-private partnership with distribution of vaccines. So it's a really, an opportunity for the country to really see how well we can ramp up. We do also have DPH being mobilized here in LA County to accelerate vaccination of this population. Then we have our essential workers. Again, some of them will be receiving their vaccine through their employee or occupational health services. Again, we think this is going to be in February and March. And then depending upon your risk, other individuals, if you have a healthcare provider, you're going to be working with your healthcare provider. They're going to be commercial pharmacies. So many of you know how to get your flu shot at the CVS. And so there will be, at this point, some way of notifying people when it is their turn. I don't have the details of that yet. And so we'll have to stay tuned. So again, timing, and again, this is all guesses, and this is what we hope to happen. I do think that there's some hope that the Johnson & Johnson vaccine will be hearing about the data and the FDA will be doing its authorization. I believe in that vaccine, the capacity for ramping up for doses is quite considerable. And so when that arrives and is available, I really do think we'll see things accelerating. So this is sort of the timelines that we are looking at. Now, what happens if you don't have insurance or a healthcare provider? There are county vaccination clinics. I was hearing earlier on, as you know, last week, that those were really not going to be mobilizing until March. But I believe that some of these clinics will be ramping up, and that is to make sure that we are getting through this phase 1A as rapidly as possible. LA County did have a little bit of lag of receiving in doses of vaccine, but that seems to have resolved, I believe. And so we're hoping that as soon as, it's just the sort of getting used to the throughput of bringing in vaccine and then deploying it into arms. So where can you get the vaccine information? This is where, this is a just sort of screenshot of the LA County website. Here's the link, and there's frequently asked questions. There's a dashboard, and this is the dashboard from today. It was recently updated about the amount of vaccine that the county has received and the number of facilities that has received and how many doses have been allocated and administered. And here you can see we really haven't gotten started on the skilled nursing facility distribution and administration. And so I know that's being started tomorrow with strike teams and DPH. So I think this dashboard is probably updated about once a week. So just sort of to wrap things up, the vaccine is here, it's being distributed. We're really trying to get it out there. But the key is right now, the vaccination of most vulnerable for severe disease and death. This is what we want to do to save lives and really open up the hospitals for not just COVID-19 patients, but for essential medical care, because we're losing as many people who can't access beds for other reasons as from COVID-19. And for most people, we're talking in our panel about the benefits of vaccination from the population perspective. But there is also the personal perspective. And so you'll be working with your doctor or healthcare provider. And if you don't have one, there are resources to discuss benefits and risks of vaccination. It's a rapidly evolving situation, but as far as the way the vaccine has been performing, it's incredibly positive from a safety perspective. Even those severe allergic reactions were very manageable. If you don't have physician insurance, you can call 211 for linkage to care. And then there's also a website called 1 Degree, LA County, that is able to help link people to care. There's also not on the website yet, we don't have vaccination clinics, but I would say in the coming week or two, as the county mobilizes vaccine clinics, that will also be on the county website. So it is a really good a resource for not just vaccination, but all things COVID. And so I just want to make sure everybody knows about that resource. All right, thank you, everybody.
Thank you all so much. That was a very large amount of information that I think but there's so many questions. I haven't counted, but I've received a ton of questions. So throughout, I think people have been very engaged and very interested in applying this in real time. I think we're probably going to try to go until 9 just to be able to answer the questions. And again, this will be recorded. So I want to emphasize one point as I bring together, I'm going to try to synthesize as much as I can with the questions. But the focus that Gil raised about how we get back to normal is really like a meta question that we're all holding. And I'm hearing just in all the questions that have been sent to us, this real, like, how do I make this happen right now? And I think that one of the beautiful parts of when Rav-Yosef talked about the joy that we can have in the vaccine is that this is really the beginning of the journey of having our hope come full circle. So we know that, we talked about the chiyuv, we talked about the obligation, and we know that we've been in fear and anxiety and confusion and distrust for a long time. And this is really the time where we're shifting into this place of real hope, and it's a turning point. So we definitely need to continue the precautions, but it's also a time to celebrate Rofei Cholim, that God has given us the ability to have this kind of healing. And I know it's all still evolving and uncertain. But I want us to sit with that question of getting back to normal, and in particular, when we think about getting back to normal, we can also ask ourselves what we want normal to be. Meaning, is it caring for others and for ourselves? Is it holiness and blessing and medical wonders? Is it the ability to come through darkness as a whole human race and find light and health? But getting back to normal really includes making normal what we want it to be. So I offer that as sort of like a frame as we move into the questions that we're going to be answering. So one of the questions that we got over and over again was about the Moderna vaccine and Pfizer vaccine, just that people have been talking about one is better than the other. And I know it was presented, there's like a 1% difference. So there's the question about how you get the vaccine and if you can choose between them, what people should choose. And then when we get when we're getting the vaccines, do we wait for phase 1 to receive both the dosage before jumping to the next phase, or are they going to go through the tiers? So will every person be able to get it in that timeline, whether it's 3 weeks or 4 weeks, and what's the significance of the 3 versus the 4 weeks?
So maybe I'll tackle the first part of your question and maybe defer to Zach or Julie with respect to the second one part. But as far as is one vaccine better than the other, at this point, the answer was no. If you take what you can get, it usually will be offered to you in some format, and that's the format that you should receive it. The slight differences that are seen between the two are not meaningful, and we have no reason to think that one is more effective than another.
So I can answer some of the tier part. So Julie did a nice job of kind of talking about the tiers here in Los Angeles County. My unit is working with the Vaccine Preventable Disease to actually roll out vaccine in 1A. So to all the healthcare workers, so we're the ones who kind of have been setting up the strategy to do that. And so I just want to say one clarification that one of the slides that Julie presented is, we've already started vaccination in skilled nursing facilities as of last week, and we have vaccinated about 2,000 people, and it's going to accelerate a lot this week and next week. So we're hoping to get through these tiers fairly quickly. And the thing about, and that kind of gets me to that second question, which is, the tiers are not, they're not as clean as they look on paper. So basically what we're doing is because, we're rolling things out to skilled nursing facilities, but then we're also hitting additional parts of the tiers as well. So we're trying to clear our way through those tiers as quickly as possible. And so we gave the vaccines to the acute care hospitals. And so they all got their, first doses, as Julie just described. And now we're on to skilled nursing facilities, but at the same time, we're now working through other groups as well that are in that tier 1A. And so we actually have set up, tomorrow will be the first day that we have actual community pods set up. So there are these points of distribution out there, almost like the testing sites that people have seen them, where you can drive through and get vaccines. So they're still fairly small, and they're what we call closed pods, meaning they're only, we're going to be driving people to those pods who meet those criteria, the 1A criteria. So we're now working with some of those 1A groups. And then next week, we're going to actually open up more of those pods. And then we're going to continue opening up more and more as we try to go through this. So we're building the infrastructure in order to hit those large tiers, that tier 3 and those other populations that we're talking like really hundreds of thousands or millions of people. So it doesn't make sense to kind of roll it out now, because right now the limiting factor is the vaccine. So we don't have enough vaccine to roll it all out. But as Julie said, the hope is that as time goes on, we'll have more Moderna and Pfizer vaccine, but then we'll be able to add some other types of vaccines as well that we can generate more quickly. So right now it seems a little bit slow, but my assumption is that it'll start ramping up really quickly, probably end of January and February, when we start. Hopefully we'll have gotten through that tier 1, or that whole 1A group, and then we'll start hitting 1B maybe in February. I know that for sure, and that's not a promise, but we're trying to get through that 1A as quickly as possible.
I think it's important, like once you've started one vaccine, you need to follow up with the same vaccine. I mean, I think Gil probably mentioned that. So that's kind of a little bit, it's complex, to make sure that everybody gets the right vaccine on the second dose. And so that's why with the Janssen vaccine, it's one dose. I think that's going to be a real accelerator because people will be one and done pretty much. So I think that's going to be really impactful.
So someone actually asked about the Johnson & Johnson one, if it's at 70% of the,
I don't think we
will
know
they release
yet.
it?
We will, I saw that Fauci said something to the fact that we are still expecting to see results in January. So really soon. So they're on, I think, on time as far as they're still at the schedule. So hopefully we'll get that initial sort of, this is how effective it is, and then it goes to FDA, and that typically takes at least a couple of weeks for FDA. But as what's been really amazing, I mean, it's incredible how quickly this has all come together, is that I think FDA has been reviewing as the trials have been being done.
Amazing. So we've gotten this question in a variety of forms. How does it look when a family gets vaccinated? How does everyone being vaccinated stop the spread if you can still transmit the virus to a vaccinated person? And then practically, if multiple people have been vaccinated, would they still need to wear masks around others, meaning parents and grandparents? You've sort of answered that in that we're going to continue with the precautions. But the question about, how we can really stop the spread if you still transmit the virus, I think is still up.
Maybe I can address that as well. So that's a theoretical concern. So there are some vaccines like pertussis or whooping cough vaccine, where if you get vaccinated, there's a concern that you actually can still be a carrier and transmit it to others. That's not true of most vaccines. Most vaccines protect you from transmitting it to others. So, but you don't know until you look. And these studies, as was mentioned, were really set up to look at different endpoints. They were looking at symptomatic disease, and they didn't look at people who may have had mild or asymptomatic cases. So that study is actually ongoing right now for both Pfizer and Moderna, and probably is going to take a couple of months, is my understanding. So we will have that information, within a couple of months. So that'll be really important to be able to kind of give additional guidance. But right now, we're recommending that people wear masks because we just don't know. But eventually, my hope is that the vaccine will be effective at decreasing the risk of transmission, and then we won't need to really wear masks after that. But again, for now, that's just not the case. So we have to wait for the data to become available.
Okay, so for someone who's asking about the, if someone who's been vaccinated, is it safe for them to be with non-vaccinated people indoors? The answer is that it's still.
Yeah, well, no. So let me be clear. The vaccine, you can't, so there's only a concern that if you've been vaccinated and that you're exposed to someone with COVID, could you get a mild asymptomatic case and transmit it to others? Not from the vaccine. So once you've been vaccinated, you're probably safer than most other people out there. But we just don't know if you can still potentially get this mild infection and transmit it to others. So that's something that that we're studying right now. But the vaccine itself, it doesn't increase your risk of transmitting it to others or anything like that we know of. It's just we don't know if people theoretically could transmit it after they've been vaccinated or not. And that's something
Okay, great. Building on that, what is the scientific logic behind vaccinating someone who's already been infected and has natural immunity? With regard to the statement that we don't know whether one who has been immunized can transmit COVID while asymptomatic, what other viral or bacterial infection can be transmitted if the person is not infected?
Gil, you want to take that one?
Well, yeah. So I think Zach had already addressed the second question, but with respect to the first question, the rationale behind vaccinating people who have had COVID, we don't know what the persistence of natural immunity is following infection. We don't know what we call them titers, or the levels of antibodies should be that confer infection. What we do know is in the vaccine trials, we have very highly studied and regulated levels that we can anticipate. So it's really based on what we don't know about natural immunity that is making this recommendation. And there doesn't seem to be any harm or in inducing additional antibodies above those that are already protected. So rather than make people go through the process of figuring out who was, who wasn't, everybody can get vaccinated.
And I actually just want to add to that because I got a question about, is there a scientific difference between herd immunity from vaccination and herd immunity from natural infection, from infection rather than vaccination? Exactly to what Gil's saying, the same goes for the herd immunity piece, because we don't know the robustness of the immunity that you might, your immune response to COVID, and because we have more and more data that indicates that reinfection is possible. Utilizing this herd immunity, natural herd immunity method, first of all, has never been a public health goal. It is something dangerous on a mass scale, because obviously COVID can cause serious disease and death and long-term consequences. So, from a public health perspective, fairly unethical, I believe. So this is not, it's not like, should we do herd immunity versus just let the virus take its course. That is not a public health goal for the most part. So some, you've heard in the news, some countries try to do this. I don't think it has been successful, and it is just not something that public health practitioners would consider.
Yeah, thanks, Sharon. I fully agree. There's one other little point on that from the CDC recommendations, that if you've been infected with COVID for the 90 days after your infection, you are considered to be really immune from that infection. And based on that, if you are offered a vaccine during that time, you don't have to take, the recommendations are you don't have to take it during that time. You can, but you don't need to, and you could pass it up to somebody else. So that initial 90 days after infection might be a time where you can be considered to be protected.
Yeah, and I can say that about the 90 days, at least for the public health rollout of the vaccine, like in skilled nursing facilities, we're just vaccinating everybody. So, because we just don't know how long it's going to last, and this is an opportunity to make sure we get in there and get as many people the vaccine as possible. So we're just vaccinating people, regardless of their their past history of infection.
A quick question on that. Is this going to be an annual vaccine like the flu vaccine, or a once in a lifetime one like the measles one?
We don't know.
Okay, awesome. So quick question, quick answer. Okay, so next question. There's a lot of questions about other states and other countries and how they're dealing with this, and also the UK version of COVID, and if this vaccine will fight against first the UK version, as well as why it is that other states are dealing with this differently. Some people have shared in their questions that they prefer how Florida or Texas or other places are dealing with it. And so the question also of, why is it that certain countries like Israel seem to have everyone getting vaccinated far ahead of us? Why are we seeing such different things out there? So the first part is the UK strain. The second part is about the different states and countries and how they're handling the prioritization and why it feels like we're going more slowly.
I can talk about the UK strain. So the UK strain is not the first variant of COVID. So there are a number of different strains of COVID that are circulating in different parts of the world and probably different parts of the country here. But the important part of that, and so some may be more infectious than others. It's a little bit unclear still whether that's true or not. So there's ongoing studies for that. The interesting thing about COVID is, and coronaviruses in general, is that one part of the virus that is conserved across all of the different the virus types, subtypes, is that spike protein that Gil talked about. And it looks like the vaccine is effective against all those different variants, even though there's some slight genetic differences between the viruses. So right now, at least, unless there's a really big change in somewhere in the world in the spike protein, it appears that the vaccines are going to be effective against all the circulating coronavirus that we know about right now. And about how different countries and different places are rolling out vaccine. There's different societies have different goals and have kind of laid things out and are different places in their COVID response. I can tell you in Los Angeles County right now, we have more COVID cases in the hospital and more COVID deaths and cases than we've had, at any other time during the the outbreak. And so I think there, and we have a lot of healthcare workers that are getting sick. And right now the healthcare system has really become overburdened with COVID. And there's all kinds of really dire problems out there in the community, with hospitals running out of oxygen, hospitals, being full, having to take care of, double, triple, quadruple the number of ICU patients than they're used to. So it's really getting very difficult. And so I think actually it made sense to vaccinate healthcare workers first, to kind of make sure that they would be around to continue to take care of these patients and not getting sick and missing time. So I think that was kind of the goal, because the United States has been so impacted by COVID, and we have so many patients that are in the hospital now. I think that was probably part of the calculus when they were making those decisions. I mean, it is different in Israel. I mean, the population of LA County is basically, almost the population in Israel. So, in a country so large, we just don't have the same kind of vaccine coverage as easily as they do in Israel, where they can, buy a relatively small number of vaccines compared to what the United States needs. So here it's just a different way that we have to roll it out. It would be nice if we could just roll it out to everybody at once, but that's just not the reality of the way it's working here. So it's frustrating for a lot of people to have to wait, but everybody will get vaccine. I mean, we'll have enough vaccine for everybody to get vaccinated by the, hopefully by the summertime. But it's just right now it's really frustrating because there's smaller numbers that we're having to roll out, and each state has their own plan and has made, kind of generally each state has a similar plan to what we have, but there's some little variances depending on what the goals are of each individual jurisdiction.
Amazing. Shifting to a few practical questions that are coming through. Questions like, when will we be able to travel again? Once phase B is done, meaning for educators, will schools be reopening? Those kinds of questions.
Those are hard questions, and I don't know that we can answer them yet.
Yeah.
I mean, I think there's a lot of variables right now with the number of cases in the community in Los Angeles County, the number of people in hospitals, the number of vaccines we've been able to roll out, the rapidity at which we'll be able to get through 1A and to 1B, 1C, et cetera. So I think there's a lot of variables, and it's just going to be hard to really say when we're going to get back to these normal.
I agree. I mean, I think really this period of the next couple of months is going to be super important as far as understanding how long it's going to take. So if we can rapidly ramp up, that's going to be really impactful, and getting as many of these vulnerable people, the most vulnerable people who have the risk for severe disease, that's what's going to open up the hospital system. And I think once that happens, we're going to have, we're going to be able to operate, right? We're going to have our normal operations begin to return. It's not going to happen overnight, though. But at least when you have all the vulnerable people vaccinated, or as many of them as possible, that's when a lot of the normal things can happen again, where you can see your parents and those sorts of things. So, I mean, it's not going to happen overnight, but little things are going to start happening that are going to make us that's going to make it that we haven't been able to do for weeks or months. And that's what we're looking for. So it's just going to be a process.
Okay, thank you so much. So I'm going to try to combine a couple more questions because we're getting close to 9. The pre-vaccine, there were multiple problems with the public wearing masks. So there's a question about what the educational process will look like in terms of sort of implementing, or is it going to get worse once people get vaccinated? They're going to just totally ignore it. And the combining with that, practically getting the vaccine, how will I know when it's my turn?
I can take the second question.
The
first question is tough. Yeah, people should be wearing masks, and that's been frustrating because I think a lot of people haven't been wearing masks and been complying with the guidance. I think people are getting tired of it. And it's really sad because they feel like the end zone is in sight. We have the vaccine here. If people can just kind of hold on and be careful for another couple of months, we can get the vaccine out of here. And it's been really disheartening to have to deal with rolling out of a vaccine at the same time as our health system is kind of starting to really, see cracks in it. So that's been frustrating. As far as when people are going to know it's their turn. So I mean, right now we're dealing with kind of the smaller groups, which are healthcare workers. I mean, they're fairly large groups. We're talking about hundreds of thousands of people, but they're still fairly small. And so we're trying to target our outreach really to those groups specifically. And then once we get to the larger groups, like the age groups, above age 75, above age 65, I think it'll be a lot easier. I think you'll probably hear about it in the LA Times, and the LA County Department of Public Health will be pushing out additional information once those larger groups come. But right now we're keeping a little bit quiet about these other groups because we don't, we're trying to get through them so we can move on, and we don't want people kind of crashing a lot of our vaccine events, which makes it a lot more complicated. So that's kind of the goal right now, is just to get through those smaller groups, and then once we get to the bigger groups, we'll be able to roll out a lot more public information about how to get vaccinated.
Okay, I'm going to ask one last question, and it's going to combine a couple different things, so feel free to tackle it. Before I ask it, several people are sending in so much gratitude to each of you for your amazing expertise. Rav Yosef is going to give us some concluding words in just a moment, but everyone is saying that they're so grateful to you, and it's crazy that we have your expertise in our shul. I mean, the chances of having all of you is we're so blessed. So that's all coming into. So for the last question, there's concerns about people who are long haulers, who are having these additional symptoms. Are they, even after 90 days, should they still be getting vaccinated? Really like the reactions that people get with vaccination as well. How long does that last too? And finally, the question about Bell's palsy with the high profile vaccine side effect, and whether repeated proclivity for this virus-based ailment should make a vaccine recipient concerned.
Yeah, so I'll start, and if anyone wants to chime in, certainly in the clinical trials, pretty much they enrolled healthy people, and so we don't know some of the subgroups of particular individuals, but what we think we know, based on what we've learned so far from the actual clinical trials, as well as the vaccines that have been administered outside of the trials, is that very few people would fall into categories that should not get a vaccine. I saw a question about blood thinners. I've been asked about immunosuppressive medications, people with certain kinds of medical conditions, cancer, et cetera. None of these are reasons not to get the vaccine. As far as the long haul implications of having previously had COVID, I think that's a question we don't really know the answer to. I'm curious if any of my colleagues, I see Julie nodding her head. From a mechanistic standpoint, I'm not sure there's a reason to be concerned about vaccine responses in these individuals, but we just haven't done it.
I think that's something that deserves some special conversation. I just don't think we know at this point.
And I can talk a little bit about the side effects. The side effects that Gil mentioned in his presentation after vaccination, the median time was about 1 to 2 days. So most people had mild side effects for 1 or 2 days. So, it's not unusual for other vaccines as well. So, I mean, I think people are very concerned about a new vaccine, and I understand why, but, but at the same time, you have to kind of look at what the alternative is. Right now, the alternative is getting COVID, and, 1 out of every 12 people ends up in the hospital with COVID. And out of those 12 people in the hospital, maybe 2 of them end up dead. So, the vaccine has been now given to 2 million people, and we've seen a handful of side effects that are actually fairly mild and have resolved for the most part. And so I think that's the bottom line, is this is a safe vaccine, incredibly safe vaccine, 95% effective, which is probably one of the best vaccine responses we have of any vaccine we've ever studied. And it really protects you from almost 100% from getting severe COVID, which we know kills a lot of people. So I think the bottom line is, you want the vaccine as quickly as possible. And that's what we want to do, because too many people have already died of this virus. And the vaccine, like I said, is the way to get out of this. And I don't see a lot of other ways to get out of this at this point. So vaccine is really crucial.
Thank you all so much. Rav Yosef is going to now conclude.
Well, thank you each. Not going to echo all the words of thanks, though they are felt. What's awe-inspiring about this is recognizing how many people around the country, around the world, how many people are working on getting us out of this. And it is awe-inspiring to know how many people, more than we can know or count, have devoted themselves to this and are continuing to devote themselves day and night to this work. And that knowledge of how many people are doing it comes with a flip side. And that flip side is how many people it takes. This is a crisis that requires, as we've been saying from the beginning, all hands on deck. Whether you are a scientist, and we are so grateful to the scientists, or whether you are a person who is a community member or a neighbor, whether you are someone who is a friend or a teacher, this is all hands on deck as we admire and are grateful for the many people who are doing so much. We recognize anew that without all of us working through this together, we're not really going to get to where we want to get. And we're certainly not going to bring all the people we want to bring with us to the finish line. So we've been saying since the beginning, we're all in this together. And in is the critical word there. In can be we're all living through this together, or we're all in this together. It can be we are all contributing, each in our own way, each utilizing our own resources, our own skills, our own talents and gifts to get as many of us as possible in health and in safety to the finish line, to the end zone that Zach referred to. And with God's help, we'll be able to look back and remember not only a year that was so difficult and in many ways so tragic, but a year in which we found new and deep resources within ourselves and were able to together bring about the best possible conclusion to a very, very difficult chapter. Thank you, everyone, truly everyone. And with God's help,